Yes,
Yes, I do.
but you can make it full screen. Is it better?
Okay, so today we got 3 cases. So I'll be the first presenter presenting on GIT topic, followed by my friend Norina and Nonajira. Okay, so for the chief complaint, my patient Sakti, a 2-year, 7-month-old Indian girl with underlying Down syndrome, presented with vomiting and passing loose stool and fever for 1 day duration, which is prior to admission. For history of presenting illness, patient had sudden onset of vomiting in the evening 1 day prior to admission. It was non-projectile. There was 4 episodes in the same day. Initially, the amount is 1 to 2 cups, followed by episodes of lesser amount. The vomitus contain only food particle, and there was no bile, which is greenish or blood content noted. The vomiting was followed by episodes of passing loose stool that night. There was in total of 8 episodes. Initially, it is small amount, but later it overflows the diaper. However, the mother couldn't recall the amount of diaper change that night. The stool was watery in consistency and yellowish in color. There was no blood noted, and there was no blood and mucus noted. There is apart from that, there was also fever, which was continuous in nature for that day. However, there was no documented temperature at home. It was subjective because the mother told that the child was warm to touch. There was no chills and rigor. It was partially relieved with tepid sponging, and there was no medication taken, such as syrup paracetamol. It was also associated with poor feeding. The child already tolerate adult meal diet. Since symptoms appear, she couldn't tolerate solid food, but can only tolerate bottle feeding, which is lesser amount than usual. Regarding urination, the mother was unsure about the frequency, the amount of urine output, and urine color. And upon further questioning, other family members were also experiencing the similar symptoms, which are all of them. The mother, the father, brother, and sister also had diarrhea and fever, but can tolerate the symptoms well. However, the onset of symptoms occur much earlier, but within the same day. According to the mother, there was recent history of taking outside food. The mother suspected that the recent meal that they have, which is all of them, including the child, which was chicken rice, which were bought from the store for all of the family members 1 to 2 days prior. Okay, so for the bottle feeding, the bottle hygiene is good because the mother told that she has 3 bottles and she would clean the bottle adequately and thoroughly. She would dip the bottle in boiling water twice a day after use. There was no recent ingestion of canned food, seafood such as shellfish, uncooked or undercooked meat, or unrefrigerated food. The mother also does not leave any food without covering them. And for the source of regular drinking water, the mother always boils the water, which is taken from the kitchen supply. She also stated that they are using water filter. And then they are not living in dengue-prone area. The last fogging was done last year. There was no recent history of water activity or any jungle trekking. Okay, so for past medical history, she was diagnosed with Down syndrome due to syndromic features. She was admitted for an ICU for 2 months. She was told that the child was having a congenital heart disease, but unsure what the exact disease is. There is no surgical intervention was done, as she was told that the congenital heart disease was actually a defect, and the defect was spontaneously closed. There is no information regarding the drug history. For birth history, For birth history, prenatally, the mother was advanced age when conceiving the child. She was 42 years old, and she was also diagnosed with hypertension. The doctor told that the baby was more for her for the gestational age. The baby was born preterm at 31 weeks 2 days via emergency lower segment cesarean section due to fetal distress, and there is no prolonged jaundice except for being admitted to an ICU for 2 months. For immunization history, the immunization was complete up to her age, and there is no allergic reaction following the vaccine. And for nutritional history, she is exclusively breastfed for 6 months. She was fed with formula milk. After that, and then she starts weaning at 6 months old, and she is currently eating adult diet such as rice and fruit. For developmental delay, she has delay in her development, which is for the gross motor. She cannot stand and walk. She cannot stand and walk alone. Okay, she is 2 years 7 months now, and then she can only sit steadily and crawl. For fine motor, she has pincer grabs and can point with index finger at the object of interest. For speech, she understands no and bye-bye. Socially, she can assist in clothing. So actually, for her age, she should be, for gross motor, she should be able to do, to jump with 2 feet together from a low step. She should be able to stand on tiptoe, okay, if shown. And she, for fine motor, she can build a tower of 7. She should be able to build a tower of 7 to 8 cubes and imitate straight line. And she should be able to speak in phrases, use pronouns I, me, and you, and knows full name. According to her age, she is actually the age is the delay. The delay is she is now about 9 months, 9 months to 1 year. The delay. Okay. Okay. So before moving on to the physical examination, do you have any questions? So if no question, I'll proceed with the physical examination. Okay, so for physical examination, upon general examination, she is alert, conscious, not in pain or respiratory distress. However, she appeared restless, but she is not pale or jaundice. The hydration was good with capillary flow time less than 2 seconds. The tongue is not coated. The conjunctiva and buccal mucosa were moist. However, there is sunken eyes. And regarding the skin integrity, the skin goes back slowly. And then there was also dysmorphism of Down syndrome noted, which are flat nasal bridge, low set of ears, short neck, and hyperthyroidism observed when talking. There is no other Down syndrome features such as slanting of eyes. Slanting of eyes, as all of you can see in the picture. You see the first picture. Slanting of eyes means that the macam going upwards. Contoh mata dia macam going upward. Okay. And then there is epicanthal fold. Epicanthal fold, the second picture, the upper eyelid, the upper eyelid, the skin of the upper eyelid is full, which cover the inner corner of the eye. And then there is also no clinodactyl. Clinodactyl is the curvature, bending of the fingers, and there is no also sandal gap deformity. Sandal gap deformity means that there is an increased gap between the first toe and the second toe. Okay, and she only has a flat nasal bridge and low sets of ears, and then short neck and hyperthyroidism. Okay, for vital signs, she is afebrile, evidenced by the temperature of 37.0 degrees Celsius. Respiratory rate is 30 breaths per minute, which is normal. Heart rate is 124 beats per minute, normal. And the blood pressure is 101/60, which is normal temperature. For systemic examinations, Upon abdomen examination, the abdomen was not distended. The abdomen was soft and non-tender. There is no organomegaly. The bowel sounds was normal. And on cardiovascular examination, it revealed normal apex beat. S1, S2 were heard, and there is no additional murmur. And then for respiratory examinations, revealed normal finding. And however, for neurological examinations, there is hypotonia on all limbs. Okay, so for summary, my patient, Sakti, 2 years, 7-month-old with underlying Down syndrome, presented with acute onset of vomiting, diarrhea, and fever for 1 day duration. It was associated with symptoms of moderate dehydration, such as lethargy and poor feeding. There was history of eating outside meal, and all of the family members experienced the similar symptoms. Upon examination, it revealed the signs of moderate dehydration, such as restless, sunken eye, and reduced skin turbidity. Okay, so for my provisional diagnosis, the patient is having food poisoning with moderate dehydration. The points for is there is acute onset of diarrhea and vomiting, also fever, and then the family members with having the similar symptoms. There is history of taking outside food, which might be contaminated. Then there is a symptoms of signs suggestive dehydration. And for acute gastroenteritis with moderate, for differential diagnosis, the patient might have acute gastroenteritis with moderate dehydration. Points 4 is the symptoms: acute onset of diarrhea, vomiting, fever, history of eating outside food. And then, however, the points against is family member is having the same symptoms. But what I think that the case is more towards food poisoning, because we have the source of the contamination food. For acute gastroenteritis, it could be just inflammation of the GIT because of improper hygiene, probably. But for the food poisoning, there is a source, okay, of contaminated food, which is the chicken rice. Okay, and then for different other differential diagnosis is dengue fever, because it could be acute on the symptoms is acute onset of diarrhea, vomiting, and fever. However, they are not living in dengue-prone area, and there is no rash, and then there is no hepatomegaly. For this patient, the investigation that was done is full blood count. Revealing white blood cells, increased white blood cell, which predominates neutrophil of 89, which is nearly 90%. Sorry, okay. And then the renal profile revealed elevated urea and creatinine, which is due to the profuse vomiting, profuse diarrhea, and then which could lead to dehydration. And the liver profile reveals normal liver function. And then the patient also did stool for microscopy examination. However, the result is pending. But I think probably we could add another investigation, which is stool for culture and sensitivity, as well. If stool for culture and sensitivity to find the causative agents or organism. And the management that was done to this patient is she was admitted to pediatric ward, and then since it is food poisoning, so we have to notify notify to the district health officer. Okay, and since the patient has loose fluid, so we have to replace the fluid, which to continue the Hartmann solution for maintenance. Okay. And then to encourage the mother to feed the child orally as tolerated, and then according to the mother, there's no antibiotics were given, because she was told that this is just a viral infection, and that is a self-limiting disease. And for monitoring, should monitor for the sign and symptoms of fluid overload, and then for dehydration as well, to do split input-output chart. Okay. So so I've done the case. So do you guys have any questions?
Anyone need to ask any questions?
Doctor, I would like to ask question. What are the differences to differentiate food poisoning and AGE? Is it necessary AGE to have fever?
The presenter will ask. You will reply.
I cannot hear you properly.
How can we differentiate between?
Differentiate between food poisoning and also acute gastroenteritis.
Yes.
Is it necessary for AGE to have fever? Or
So what's your opinion during your presentation? Amy.
Doctor, you asked me to answer. I'm sorry, I cannot hear you clearly. Okay, so far from my reading, basically for AGE can still have a fever, but the most predominant is the severe abdominal pain. However, according to AGE is usually self-limiting, while food poisoning is much more severe because it can be related to bacterial infections such as Salmonella, Shigella, and then as I said just now, the AGE it is inflammation of GIT, and AGE doesn't relate it to specific food. While for food poisoning, we can pinpoint the exact cause, such as contamination of the food, such as contamination of certain foods, such as eggs, cheese, or seafood. Okay. And the other difference between AGE and food poisoning is usually AGE, it will last only for about 1 to 2 days, while for food poisoning, it usually lasts longer. It can be up more than 5 days. Okay.
That's okay. Let us establish an important point. Okay. How we are diagnosing any disease, as I did now. She goes through history, clinical examination, investigations. Okay. So if you are trying to answer by this one, you will go the correct way. I mean, for history, it's completely different. For AGE or dysentery, the child has exposure, has another family member with diarrhea, he has changed his food, like that. If it is infection, he got fever, whatever the scenario. But food poisoning, it is related, number one, to consuming a separate food, because it is food. And usually it will include more than one. Usually the family eat outside in a cafeteria, and a lot of them got diarrhea, and some of them got vomiting, and some of them like that. So the history here will guide you, number one. Okay, because we cannot come from the sky and come down and say that this is food poisoning. Why it is food poisoning? So number one, history. Okay, if there any family member affected, and it is very important to be able to answer when the food poisoning, when the food was consumed, and when the symptoms started, because it will guide you about the organism itself. Some organism can start its action within 2 hours, some up to 6 hours, some up to 48 hours. Not all food poisoning are very dangerous and very severe. No, some of them, like Salmonella, is just very simple. and they even not need treatment like the Salmonella typhi like that. So you must know the duration of the food and when the symptoms are started and how severity of the symptom, and we need to send at the time a sample from stool and the blood to rule out, and we must do notification if you think that this patient has food poisoning. You must ask yourself now, I need to notify and I need to justify which restaurant, so they will send from MOH someone there to check the technique and the cooking and like that to rule out any harm to the community. So it is not only for a person, it is a part for the community. Okay, investigation is different. I think you must have very small table about food poisoning. Okay, because it can come to you in the theoretical and also in the practical one. Another question now to Amy.
Yes, doctor.
Your examination technique for the cardiovascular system. Just tell me in 2 minutes, how can you examine the cardiovascular system of any patient?
Cardiovascular examination.
Cardiovascular.
Okay. So first is to do general examination. Okay. General examinations for cardiovascular system is we have to look at the patient. The patient is in prop up position, or because if the patient is in a prop up position, cannot lie flat probably, the patient has symptoms of heart failure. And then then we have to look for the signs of infective endocarditis, looks of clubbing. Okay, for example, could be cyanotic congenital heart disease. And then, okay, moving on to the pulse. And then the patient can have radio delay. And then going upwards, maybe the patient can have a JVP. However, usually edema or JVP, it is not prominent in the pediatric child as much as the adult. And then look for is there any failure, and then at the is there any conjunctival failure or central failure, and then at the precordium, look for is there any precordial bulge, or is there any evidence of pulsations, visible pulsations at the apex beat, which tells there is left ventricular hypertrophy. And then for palpations, look for parasternal heave, and then for parasternal heave, and then the last one is to look for to hear for the murmur. So in this patient, which is Down syndrome, the complications, I mean the cardiovascular complication that might arise is AVSD, atrial septal defect.
Okay, what else? Okay, so Ashraf, are you able to add anything supporting Aini?
And then for the murmur, if the presence, to have to determine the type of the murmurs, the grading of the murmurs, is it palpable trees, presence or not, and then the gradation of the murmurs. And then after hear the murmurs and then listen to the bile vessel cracks to any pulmonary edema. and then look for the lower limb edema. But as mentioned previously, that usually the children doesn't have prominent edema. Okay, and then I think for the general examination can add any dysmorphic features such as Marfan syndrome, because Marfan syndrome also has the special cardiovascular problem, which is coarctation of aorta. Okay, besides the Down syndrome features.
Okay, anyone else need to add? One can add to the to the examination of the heart. Yes.
For Marfan syndrome, maybe there is a special at the mouth, which is high arch palate.
Okay, you mean the criteria for Down syndrome?
Oh.
Okay, who else need to add? So if I came now to is that all? Is that? Are you around?
Means other physical examination. Is it, doctor?
No, I'm asking you about the how can you examine for dysmorphic features generally?
So in general, for dysmorphic features, first look at the patient. So examine from generally from upwards to downward. So inspect the detect the features of Down syndrome itself from the eyes, from the mouth, and then look at the features of the Down syndrome itself, such as mentioned by the presenter just now, such as broad flat face, slanting eyes, replicated full, short nose, and then inspect also at the mouth. Is there any presence of arch palates? Wrinkled tongue, and also for hands, is there any short and broad hands? And then proceed with the look also at the lower limb. Is there any big toe wide space between first and second toe? And also, is there any presence of single palmar crease or short fifth finger that curve inwards?
Okay, so Najira,
Yes, doctor.
how can you examine for dehydration degree?
For degree of dehydration, we can classify them whether it is mild, moderate, or severe. So we can look for the mucous membrane, for example, the mouth and also the tongue. Other than that, we can also look for the sunken eyes, and then the skin turgidity, as well as the fontanelle to look for the dehydration.
That's all?
We can also look for the conscious level of the patient, whether the patient is early or not, because those patients with severe dehydration can present it with confusion.
What else?
And other than that, we can also look for the capillary fill time, which can be prolonged in those dehydration with moderate or severe classification of dehydration.
So do you see how many times I asked you what else? It is not good. What else?
Other signs of dehydration?
Yes. Norina? What important thing is she missed?
The blood pressure of the child, because it's severely dehydrated, so the blood pressure can be low. The respiration, if moderate and severe dehydration, the respiration can be fast, and also you can look at the mucous membrane of the child. Maybe if mild, then the mucous membrane is moist. If moderate, then the mucous membrane will be dry, and if severe, the mucous membrane will be parched. You can also look at the tears of the child.
What else?
Sorry, doctor?
Good. What else?
Okay, tears. Then eyes.
What else?
Sorry?
Okay, you finish with the eye. Something and the tears. What else?
Okay.
I need you to complete here, not to repeat here.
For the tears?
Anyone can answer. One important, two important, two important. Sorry? Again.
Is it urine output, doctor?
Urine output are very important, of course, because AKI. What else? Did you ask about skin trigger?
Skin trigger.
This is one of the most important tests, skin trigger. It is not so simple thing, please, skin trigger to check for dehydration. If you didn't do it, you are in danger. What else? The weight of the patient is important. How can you classify the dehydration score?
We can divide the dehydration into mild, moderate, severe.
Depending on
depend on the general condition of the patient. If the patient is unconscious, so it means severe.
No. Before coming to this one, no. Before coming to this one, you will find in the top of the table degree of dehydration the patient lost from 0 to 5 or 5 to 10 and more than 10 or 1 to 3, 4 to 7, 7 to 10. It's very important to know how much is the loss of weight. It will guide you. Even in DKA like that, you must know that. Okay, this is a very nice case. Just give us a mini lesson. I don't know your colleague in year 5 before send me what is your flow for examination. Okay. You are in critical time now. We need to finish our posting and then maybe another remaining posting, and you must come to us for the final pro within very short time. Your flow of examination must be very, very clear. Am I clear? You must know your roadmap. If I asked someone of you how to examine the cardiovascular system, or even any system, you must be able. I'm going to introduce myself, and this introduction need a lot of things. Introduce myself, getting permission, contact with the patient, washing my hands, positioning the patient, go to the right side of him, and expose the needed area. Or this is the first job. Second job, as your colleagues speak, I need to observe. Okay, the observation is not only I will observe if the patient is dysmorphic or not, like this patient who is Down syndrome. I would like also to ask myself by observation if this child look small or overweight. If he's small for weight or short or like that, I must ask myself. I need to plot it in Untitled Chapter to see is crossing a centile or not. This by observation. He has any acute condition or not. It is very important. So a lot of issue from introduction, from observation, and then when you are going to start the examination, you must start by the peripheral. Any time you are going to examine, you must start by peripheral and ask the child to give you 5 and get a look for the hand. Is there any cyanosis? Because we are speaking about Down, which has 50% susceptibility to good congenital heart disease. So is there any clapping or not? Is there any bacterial endocarditis or not? Is there any jaundice? Is there any pallor? Is there any crease abnormality? All this must be able, and then you must say, I am going to check the vital signs. And the vital signs are vital. Okay? Remember, vital signs are vital. So I will check vital sign. Now I will check the pulse. How to check the pulse? You must know. Check bilaterally and radial and radiofemoral delay. You can do it within 1 second. Blood pressure, you need to tell. I'm going to check the blood pressure for any hypertension or other problems. Okay? Respiratory, you must count because if the patient has severe dehydration, as your colleague spoke, he can put the cosmal breathing, okay? Deep breathing due to severe metabolic acidosis. So this is very important. Start by introduce and with its many points and observation, and then start by peripheral examination before coming to the system itself and examine it, either heart or chest or abdomen or nervous or cutaneous or whatever. You must examine the system by inspection, palpation, percussion, auscultation, okay? And at the end, you must ask number 5, what else I need to examine? Okay? It is very important. Number 1, is there any organ failure? Like we are speaking about a case of heart. So you need to know, is there any organ failure? So I need to ask myself, what about heart failure? How can I confirm if there is any heart failure? Anyone knows? Najira? How can you say is this child in heart failure or not?
So for heart failure, the patient can present it with cyanosis or respiratory distress, and then they can also present it with edema. However, it is less common in children. The edema can be by vasocrepitation or increase in JVP or lower limb edema, and then the patient can also have hepatomegaly for heart failure.
Okay, what else? Good. You started to have global thinking, which I need all of you to have this ability, how to think globally and to go deep for the patient. What else? How many types of heart failure do you know?
For heart failure, it can be further divided into left and also right-sided heart failure. For right-sided heart failure, the patient can also present. The patient can present it with increased JVP, lower limb edema, and also for the that one right-sided heart failure, lower limb edema, increased JVP, and also hepatomegaly. For left-sided, the patient can present it with pulmonary edema.
So you need to examine the chest, yes, to see if there is any fine crepitation or not, which are very important. So don't forget to examine the liver, as you told, beside edema. You must examine the liver, you must examine the back of the chest for crepitation or signs of heart failure, okay, which is pulmonary edema. This is very important. So else I need to do. Okay, so please make this as an habit. If you are going to examine for dysmorphism, you must know how to interpret whatever the abnormality do you have. So you must start number one, as I told you, by observation of the child and his family. Is there any symmetry? It may be something familial or not, his father or his mother. Number two, what about his nutritional status? He is obese and short, or he is tall and slim, and he is very important because short stature syndromes are different from long stature. At the same time, you must go after that about he has any acute condition or not, and then you are going to ask yourself about the facial features, number one, and you must be systematized. I would like to examine the eyes. So the eyes, I need to check for blah, 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 blah. Okay. The size of the eye, the slanting, the third lid. What about the level of the eye? Is there any brush-filled spots? Is there any other abnormalities in the eye? Almond-shaped eyes, like that. So I must finish eye. Don't sit some for the eye, some for the ear, some for the eye. Again, it is not good. And then you must speak about the nasal and nasal bridge. You must speak about the mouth, and is it high arched or not? What about the mouth in relation to tongue? How is the characteristic of the tongue, which is known as fissured tongue, like that? What about the ear? What about the neck? All this must be very clear. And then when you come to hands, must be able to comment about the hand completely. What about the hand? Is there the thumb is characteristic? The other finger, is it short? Is it broad? What about the simian crease? What about the clinodactyly? What about cyanosis? What about clubbing? And then you must go for the heart, and you must go for the chest, and you must go for the abdomen, and you must go for skeletal. And don't forget genitalia also, because genitalia sometimes of the characteristic of the dysmorphism. Okay, so please, you must know your flow. In the exam, you have a restricted time. You mustn't give us a piece of cake. You must endorse it to your examiner, the complete cake. Otherwise, you may be in trouble. Am I clear?
Yes, doctor.
Even for simple things which is recurrent and you are presenting it today, I need three candidates to complete the story for me about dehydration. It is very difficult to diagnose the dehydration with asthma. This is the most common cases in pediatric. So you must take care, please, and be very, 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 very meticulous. The method of examination, it is supposed every one of you has put his own way of examination and has his put chart, but make sure that you updated it. And I didn't want to ask you to make it because time is running, is so rapid for you, so take care and don't be haphazard. Okay, you must know the system. Good. Let us, I think you got this lesson, okay, because this is 3-in-1. We are examining now the cardiovascular system for the heart. We are examining for the Down syndrome. We are examining for the dehydration, and you must be able to answer why we are the dehydration is a bit dangerous for Down syndrome. Okay, he is susceptible for dehydration. Okay. So take care. Also, the causes of diarrhea, you must be able to divide it IV about enteral and parenteral. Okay, I mean by the enteral, it is a problem with the gut itself. Parenteral, it may be a part of systemic disease like dengue, like otitis media, like all of this. Okay. For investigations also, I am advising you to be systematized. So if you ask it for what investigation do you need to consider for any case, you must get breath, and think about four types of investigations. Number one is the lab. Number two is the RAD. Do I need to do any radiological investigation for this child or not? Number three is the bedside test. Bedside test, usually every disease has its own bedside test. Like this patient, I need to weigh him. I need to do blood gas if severe dehydration. This is a bedside test. If patient in severe asthma, I need to use my hands, okay? Number one, I would like to check pulse oximeter. Number two, I would like to check the blood gas, arterial blood gas. Number three, I would like to peak expiratory flow rate. This is a bedside test, so you must know. Number one, the lab. Number two, the RAD. Number three, the bedside test. And the last one, which is very important, it is a combination of this, but what is a specific test for this disease? If I ask it here, she will not forget that the patient needs to do urea electrolytes, because this is a gold standard. She may need to tell me, I need to do stool analysis either for rota, for infection, for whatever. So if she didn't specify that she need to do electrolyte, how can she know what type of dehydration she is going to treat? Hyponatremic or hypernatremic? What about potassium if it is low? What about the renal function test if impaired? How can I check the degree of dehydration from even the blood, which is increasing hematocrit? So it is very important to know now specific. If I asked you, this is nephrotic syndrome. So the gold standard for here is the urine and albumin in the blood, and like that, the four criteria. The gold standard for glomerulonephritis is C3 and C4. For systemic lupus, I would like to double strand. So at the end, you must be able for investigation to be also systematized. Lab, RAD, bedside, and special tests. Okay. Am I clear?
Yes, Doctor. Doctor, I would like to ask, just now you said that for the general examination, it also includes genitalia examination to look for any dysmorphism.
Yes.
So during the examination or when we inspect the patient, we should open the diapers, the trousers of the patient, right? During that time.
Yeah. Even for forget about. I give you experience for life. For exam, it may be there is some limitation, but any time you examine infant, you must examine the diaper area, okay? Because it may be number one. Sorry, if the baby has diarrhea, you will see what is the characteristic. Usually, you are endorsing it to me what is the score of the diarrhea, okay? So you must be able to go through it. Is there any blood? Is there any mucus? What is the color? What is the odor? What is this? This looks like investigation for the stool by inspection, which are very important. Is there any irritation in that area causing diaper dermatitis or not? Okay. Is there any abnormal? Like if the patient comes to you with signs that looks like vomiting and dehydration, sometimes he has like congenital adrenal hyperplasia, which has abnormal genitalia. Okay, so it is very important. Sometimes it can guide you. So make it as a habit for a small baby, but for elder one or adolescent, it is not allowed until you need it, and you must get permission from the family and inform the child that you are going to examine. I need permission from the family and informing him an exam after permission from the family. Okay, but it is very important. It will give you a lot of important things. Even sometimes you open the diaper and found the cola color urine are changing in the diaper in front of you. So you know now what is the issue. Maybe AGE, maybe. So it is important, please. If you need to be a good clinician, you must be systematized, you must know your way, you must build up your software to differentiate, because all of you, I found you said there is no, no. And when I started to ask what is the significance of every note, it's very important, of course. What is the significance of every no? You must be able to tell me. I said, no cyanosis, I rule out congenital heart disease. Like that, there is no blah, because of bacterial endocarditis. There is no this because it is dehydration. Okay?
Okay, doctor, thank you.
Let's go for second case and try to make it as if you are in the exam now and you are going to present it to me only 20 minutes. Okay?
Okay, doctor.
One moment.
Okay.
Najira, can you start first because there's problem of me sharing the slide.
Okay.
Can you see my slide?
Yes.
Yeah. Okay, make it full screen, please.
All right.
No more coffee? Yes. No coffee? Coffee, no. What is this? Nothing here? Okay. Alhamdulillah.
Can I start now?
Yes, good.
Bismillahirrahmanirrahim. Now we'll go to the second case, which is streptococcal glomerulonephritis. So these are my contents. So we'll go to the history taking first. This is Faris, 9 years old Malay boy with no non-medical illness, was presented to HDA with complaint of left flank pain for 1 day duration, which is associated with facial puffiness and also tea-colored urine for 4 days duration. So initially he was apparently well until 4 days prior to the admission when he developed facial puffiness and also swelling around the eyes upon waking up in the morning. It was sudden in onset and not painful and not associated with any overlying skin changes, for example, redness and also itchiness. The swelling was also claimed to be prominent in the morning. However, it is gradually resolved towards the evening. Otherwise, the patient denied any history of leg swelling or scrotal swelling, no shortness of breath, did not have any abdominal distension, no marked increase in weight, and also no history of recent insect bites or any known allergy towards any food or drugs. So besides that, the patient also claimed to have tea-colored urine 4 days prior to the admission. The color was described persist throughout the urination and also frothy in nature. He denied any presence of fresh blood passing in the urine and also denied any pain during maturation, no urgency, no increase in urinary frequency, and no foul-smelling urine. The amount was claimed to be normal. And 1 day prior to the admission, the patient started to develop pain at the left flank. It was sudden in onset, not continuous. However, it is throbbing in nature. It was also non-radiating. The pain is exacerbated upon movement and also pressure. However, it does not worsen during maturation. And there is no any relieving factors. The pain was initially bearable, but gradually worsening in frequency and also intensity. The patient was then immediately brought to the hospital by his parents. And then at the ED, the patient was found to be hypertensive upon arrival, but denied any hypertensive symptoms, for example, headache, seizure, vomiting, or palpitation. The patient also have no complaint of skin rashes or abdominal pain, and also no previous episode of the similar history before. The mother also denied any similar symptoms in the family, and also no family history of renal disease or autoimmune disease. So upon further questioning, it was revealed that the patient is having history of fever 2 days prior, 2 days duration fever, 2 weeks prior to the onset of the facial puffiness. And the fever is also associated with sore throat and also pain at the upper lateral aspect of the left neck, which exacerbated upon touch. However, he denied any palpable swelling or overlying skin changes at the painful area. During the febrile episode, he had visited a local clinic and was told to have injected throat, and he was treated with syrup paracetamol and the symptoms resolved. Otherwise, during the febrile episode, he denied any skin rashes and also no symptoms of respiratory tract infection, such as cough, runny nose, shortness of breath, and also chest pain. And for past medical drug and surgical history, he is no known medical illness, and this is his first hospitalization, and he did not take any medication. For immunization, his immunization is up to his age with no additional vaccine or allergy. And for birth history, antenatally, it was uneventful. For perinatal, he was born at 40 weeks via spontaneous vaginal delivery with the birth weight of 3.5 kilogram. Postnatally, he had history of admission to the special care nursery for 2 days because of neonatal jaundice and had received phototherapy. For nutritional history, he is currently on adult diet and had 3 main meals per day, and each meal contains a plate of rice, some vegetables, and also chicken and fish. For developmental history, his developmental milestone was up to his age. Family history, he is eldest out of his 4 siblings, and no history of malignancy run within the family. For social history, he is currently in standard 3 at SK Indra Mahkota, and he socialized well at school, participated in sports, and also able to understand the lessons taught by his teacher at school. For his father, he works as a businessman, while his mother is a teacher, and the household income is around 3,000 per month. His father is a smoker, and the patient lives with all his siblings and also parents at a terrace house in Kampung Pancing, Kuantan. So before I move on to the physical examination, is there any question? So if not, I'll proceed with the physical examination. So this examination was done on 3rd day of admission. Generally, he is alert, being under room air, not in pain, and also not in respiratory distress. There is no facial puffiness and also preorbital swelling during that time. And granula was attached at the dorsum of the hand. However, there is no any active infusion. There is also a urine bottle noted at the bedside, which contained the tea-colored urine, and the patient had no pedal edema. For vital signs, all were normal, include his blood pressure, which is 100/62 millimeter mercury, which is normotensive. And for abdominal examination, all was normal, no abdominal distension, and also no shifting dullness noted. And the renal punch was negative to rule out pyelonephritis, just in case. And also a respiratory examination, cardiovascular, and also neurological examination revealed no significant findings. In summary, this patient, Faris, 9-year-old Malay boy with no non-medical illness, was presented to HTA with complaint of left flank pain for 1 day duration, and also facial puffiness and hematuria for 4 days duration. Further questioning revealed that he had history of a fever for 2 days duration with sore throat 2 weeks prior to the onset of the facial puffiness. Otherwise, he had no history of hypertensive symptoms, no dysuria, frequency, urgency for smearing urine, no history of skin rashes, joint pain, or abdominal pain to rule out HSP, head swelling purpura. And also for the physical examination, it revealed that the patient is having tea-colored urine within a urine bottle by the bedside. So my provisional diagnosis would be post-Streptococcus glomerulonephritis because the patient is having hematuria and also facial swelling preceded by the acute pharyngitis 2 weeks prior to the presentation. And then the risk factors, as the patient is aged between 6 to 10 years old. He also presented with hypertensive upon arrival to ED, as well as flank pain. So my differential will be nephrotic syndrome because the patient is having facial edema, frothy urine, boy, and the age is risk factor between the age of 2 to 9 years old. However, there is no any evidence of hyperlipidemia, and he had hematuria, hypertension, and also URTI prior to the swelling. My second differential would be IgA nephropathy because the patient also have facial edema, frothy urine, boy, and also hypertension as well as hematuria. However, there is no oliguria and no family history of kidney problem in the family. And also he had history of URTI prior to the onset of the swelling. The next differential is lupus nephritis because of the presentation of facial edema, hematuria, and also frothy urine. However, this patient had no arthritis, malar rash, Biscott rash, more ulcer, chest pain, bleeding tendency, or pallor. And for UTI, it could be differential because the patient presented with flank pain, fever, hematuria, and also frothy urine. However, there is no any other symptoms such as dysuria, incontinence, urgency, or oliguria. Last one is HSP because the patient is having edema. However, there is no arthritis, rash, or abdominal pain. Other than that, the patient also had history of URTI prior to the onset of the swelling. Other differential that could be added includes the heart failure because of the edema. However, there is no other symptoms of heart failure noted in this patient. So we'll go to some of the discussion or review about this acute glomerulonephritis. Acute glomerulonephritis is actually an abrupt onset of one of the features of acute nephritic syndrome. So these are the features of acute nephritic syndrome, which includes the edema, as the patient can present with facial puffiness. And second one is microscopic or macroscopic hematuria, evidenced by tea-colored urine or smoky urine. And then third one will be decreased urine output or oliguria. The fourth one is hypertension, and the last one is azotemia or high urea level. The causes of this acute nephritic syndrome could be post-streptococcus AGN, post-infectious AGN, which is other than group A beta hemolytic streptococci. Other causes could be subacute bacterial endocarditis, HSP, IgA nephropathy, hereditary nephritis, SLE, as well as systemic vasculititis. However, the commonest cause of this AGN is post-infectious AGN, mainly due to post-streptococcus infection of the pharynx and also skin infection. And those risk factor for the post-strep AGN is those with age of 6 to 10 years old. In terms of investigation, we can do urinalysis and culture to look for evidence of any hematuria, which can present in all patients with nephritic syndrome, and as well as proteinuria, red cell cast, and other cellular cast, as well as pyuria. As for this patient, it shows that the patient is having protein with 1.5 gram per deciliter, and erythrocyte level is 250 cell per unit liter. It shows that the patient is having proteinuria as well as hematuria, and the nitrite was negative in this patient, and the leukocyte is not elevated because from this we can rule out the UTI. However, other parameters are normal. For full blood count, we can look for evidence of anemia and also leukocytosis. For this patient, the HB is 9.5 gram per deciliter, which shows normochromic normocytic anemia. However, there is no any leukocytosis, and other parameters are normal. The next one is a renal function test to look for the urea and creatinine level, to look for any signs of acute kidney injury. However, for this patient, creatinine is high, however, urea is normal. Creatinine is 89 milligram per deciliter. For the complement level, we can also do complement level to look the signs are suggestive for acute nephritic syndrome because those with nephritic syndrome, C3 would be low at the onset of the symptoms. However, it can be normalized after 6 weeks. However, for C4 level would be normal in posterior AGN. As for this patient, the result pending during that time. Next one is bacteriological and serological evidence of a strep infection. We can do anti-streptomycin O titer, which can be raised in posterior AGN, which is more than 200 international unit per milliliter. However, the result is depending for this patient during that time. And other than that, we can also do anti-DNase B if available for better serological marker of preceding. And then we can also look for strep skin infection by doing the throat swab or skin swab. However, the result pending during that time. And ultrasound is not necessary if the patient is having clear cut of nephritic syndrome features. Renal biopsy can be indicated in those these criteria. First one, in those with severe acute renal failure, which require dialysis. Second one is those features that suggestive non-infectious AGN as the cause of the acute nephritis. And the third one is delayed resolution, which oliguria persistent for more than 2 weeks, azotemia and hematuria persistent for more than 3 weeks, and proteinuria persistent for more than 6 months. In terms of management, we have to strictly monitor the nephrotic chart, which includes the fluid intake, urea output, the BP, and also the weight of the patient. And then we can also give them antibiotic in order to eliminate the strep infection by giving the penicillin V for 10 days duration. Other than that, we can also offer fluid restriction in order to control the edema and also to prevent the patient from develop overload. And we can do the fluid restriction until the diuresis and also the blood pressure of the patient is controlled. Other than that, we can also offer diuretics in those with pulmonary edema, antihypertensive agents such as nifedipine. And then for diet, we can also offer a non-added salt diet and also fluid restriction. However, fluid restriction is unnecessary for posterior AGN. Other than that, we have to also look for the complications of posterior AGN. For example, acute renal failure, electrolyte imbalance, hypertensive encephalopathy, and then that's all for my presentation.
So do you need to ask her any questions before she go to Oski? Everything is clear? Can you hear me? Everything is clear?
Yes, doctor.
Okay, so Ashraf.
Yes, doctor.
Why the color of the urine is cola or tea color?
Because of the hematuria, doctor. So it can present with the tea colored or smoky appearance.
So why not fresh blood? Blood, you said hematuria. So suppose it is blood. Why tea or cola?
Because it's not lower urine, not bleeding at the lower urinary tract system, and then also is it due to oxidize? No. The blood has been the hemoglobin.
It looks like hemoglobinuria. Yeah, this is a very important point. Okay, if you found fresh blood, so you must think about either it is lower urinary, which is the same like GIT. With the GIT, you can find if someone bleeding from up, it will come down as amylina. If it is fresh blood from the lower gut, like bile or like that, it will come as a fresh blood. Here is the same. If from lower urinary tract, it will be fresh blood like cystitis, like stone, like that. If from the upper, the blood will be distracted and turned into hemoglobinuria, which is color is not fresh. It is either tea or cola color. Okay, unless there is severe malignancy which can cause erode vessel and do like that. But if it is at the level of the glomeruli, you must know it is usually cola color. Because some doctors, when saw patient with hematuria, still thinking it can be glomerulonephritis. This is different. Okay. Good. You can finish your OSCE, please.
Can I proceed with OSCE? Okay. These are my question for you all. Can anyone describe the lesion? The first picture above.
So the first picture will be the strep pharyngitis. And then for the second picture, it's like the honey crusted. So it will be the impetigo skin infections.
Okay, true.
And then, okay, so for the number 2, if the patient come with the edema and hypertension, most likely is nephritic syndrome. So if post that SGN, PSGN.
Okay.
And then for the management is according to the patient condition. So if patient come with the nephritic syndromes, so we have to strict monitoring and also give antibiotic to eradicate the strep, so which is penicillin. And also because patient in fluid overload symptoms, so fluid overload condition, so we have to give the diuretics and also restriction of fluids, and also diet also. No added salt diet.
Okay, that's true. So like Ashraf mentioned just now, this is the picture of the strep pharyngitis and also strep skin infection, which is impetigo, and it is caused by post-strep AGN. In terms of management, according to the symptoms of the patient, as the patient is having edema and also hypertension, we can also give strict monitoring of the fluid intake. Just now I've mentioned antibiotic, fluid restriction, and diuretics if there is pulmonary edema. Diet with no added salt diet. Okay. Next question is 10-year-old boy presented to clinic with complaint of hematuria and facial puffiness for 2 days duration. On examination, there is multiple lesion over the shin bilaterally. So what are the important features that you will look for? Any volunteer?
The other important feature that I'll look for, since the patient is coming with hematuria, facial puffiness, so it is nephritic, as well as there is multiple lesion over the chin, which is suggestive of could be skin infection. So the other important feature is oliguria, and then high urea, which is azotemia, and then hypertension. And then the probable cause of this condition is acute glomerulonephritis, and the complication that can arise, as already explained by the presenter, which is hypertensive encephalopathy, acute renal failure, and then electrolyte imbalance.
Okay, true. Good, Amy. As I've mentioned by Amy, these are the answers for those questions just now. Any question? I think this is my last presentation and this is my reference.
So Najira,
Yes?
why this patient got encephalopathy?
Why the patient develop hepatic encephalopathy? The patient can develop hypertensive encephalopathy because of those postural IgN can also present with hypertension because of the symptoms, the features that is need to be monitored is the complications such which is hypertensive encephalopathy.
What is the cause of this hypertension?
The causes of hypertension, because it can be the electrolyte imbalance.
Hypertension. What is the cause of hypertension with this AGN?
There is less fluid coming out, resulting in oliguria. So there is an increase in fluid in the vessel.
So it is fluid overload.
Oh, fluid overload.
It's very important because if you don't know that, if you come to the previous one, the previous slide, there must be fluid restriction up to 400 ml per square meter. This can adjust the blood pressure in a considerable part of this patient. They may not need to give them any antihypertensive, okay? And the encephalopathy, how is the presentation? The question is still for Najira.
Yeah, doctor. Sorry, I can't hear your question.
Is the presentation of encephalopathy at the time?
What is the symptom?
Yes.
We presented with irritability, headache, vomiting, blurry vision, or even coma, and also blindness, nose vomiting.
Yeah, very aggressive, you will kill him. Yeah, usually it will come with convulsion also. Most commonly, and this is an important lesson. Just some patient came to us in the emergency for convulsion. We are running now to think about the problem about that. But I used to send one of the staff to collect the history because you need to stabilize the patient, but there must be someone else he collected the history. So blah, 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 ask, there is no epilepsy, there is no convulsion in the family, this is the first time. Has anything? The mother just tell him, I can see his urine is changed. How is it changed, mom? It looks like tea. So we changed now our direction of thinking. It is not just CNS problem, it is glomerulonephritis presented by fluid overload, and so this is a very important to take a lesson about that. Okay. So now how can we differentiate IME between the nephritic and the nephrotic?
Doctor?
Yes. Nephrotic and the nephritis. How can we differentiate?
Nephrotic usually the main thing is proteinuria, while for nephritic there is a red blood cell count. And then for nephrotic usually come with symptoms of fluid overload such as periorbital edema, facial puffiness. However, for nephritic it's more towards hypertension. But nephrotic can also come with mild hypertension, and then the protein in the nephrotic syndrome is much more. The amount is much more higher than the nephritic syndrome.
So you must go, all of you go and read sample table in the last edition of Nelson about the comparison between nephritic and the nephritis. Okay. The causes of disease also, especially for nephrotic, must be able to differentiate between is it primary or secondary. And this is an important lesson for all of you, okay? I mean, if it is nephrotic syndrome, or even sometimes nephritis, we need to ask ourselves, now I can diagnose this is nephrotic or nephritic. This is the stem. It is like a tree. Any tree has root and fruit. Yes? So what is the root? It can be secondary to SLE, drugs, medication, infection like hepatitis. So you must know what can be behind. That's why you must ask all this during the history. You must know about the secondary causes of nephritis or if nephrotic, and you must include it in your questionnaire for the history. Let's put in infection before, any hepatitis, any drug like chemotherapies. All these are very important. This is the root. What about the fruit? Is the complication. So this is another point which will give you how broad you must deal with the patient. Okay, I must be systematized, I must be observer, I must be have a good flow, I must check the organ failure or not, and at the same time, I must think about what is behind this one. If it is not primary disease, what can be the cause? And the last step, what is the complication? Okay, because many cases of nephrotic syndrome you will find during the exam only have Cushing, which is a completely different. And most of you cannot comment wisely about the Cushing syndrome, which is due to steroid therapy. Okay? And this is an important lesson for you. You must know what is the Cushing syndrome, how can I examine for it, starting from the face, moon face, starting from the buffalo hump, starting from stria, starting from hypertension, hyperglycemia, proximal myopathies, a lot of things you must know about diabetes, okay? Which are very, very important. The other thing is root and the fruit, okay, are very important to put your differential diagnosis. It must be very clear for you how to differentiate between nephrotic and nephritis. And of course, the general line of treatment. So what is the general line of treatment here? Najira? General line, don't speak more, just the first one, second one, third one.
For nephrotic,
Nephritis.
You can give the antibiotic to eradicate the infection, and then you can give fluid restriction, and diuretics if the pulmonary edema. And then for non-pharmacological, you can give the non-adult protein diet and no salt diet, no added salt diet and no protein restriction. Generally, the principle.
Yeah, so this is the most important to have as you speak, but try to be more arranged. So generally, we need to make input-output charts. Then we are going to do the diet. Then we are going to eradicate the infection. Then we are making a follow-up, okay, for the case, especially if it has any complication, okay. And an important issue here is how to do communication with the family. Because many doctors, for me, they are not optimizing their communication skills. All of us know that, especially post-streptococcal glomerulonephritis, but not all glomerulonephritis are post-streptococcal. It may be IgA nephropathy, which is a part of systemic disease, okay, immunological one. So it is very important they are going to say, don't worry, it is a simple disease. Your baby needs just to get antibiotic to eradicate this one. And the most of the cases are okay. So me as a patient, alhamdulillah, this doctor assure me. So I will go home and I will not come back to him. I will not send my baby again. But this is dangerous. In spite it is a good prognosis, it doesn't mean it must lose follow-up. Because we know that for how long the blood is still there in the urine. Anyone knows? More than 6 months, there will be microscopic hematuria. And about 2 or 3% still have persistent hypertension for up to 1 year. So it is very important to tell him the results are very good, but we are worried about the blood pressure, about if there any microscopic blood, and about the renal function. So your child should be stick to us for about 1 year to make sure everything is okay before tell him goodbye. Okay. Another thing which is Nigeria didn't comment is the skin. Is there any problem in the skin?
This patient, the patient is having pharyngitis.
Pharyngitis, which is more common.
A skin lesion.
Because we have 2 types of strain, streptococcal strain from the skin and from the throat. Can be in the skin and the throat. The one, there is some strain can cause rheumatic fever and the other can cause glomerulonephritis. Okay? So it regards if this strain came to the skin, but mainly the skin, it will came for glomerulonephritis and the throat will came for the rheumatic fever, but it can be also having the other one, but with a less incidence. Okay? Good. Do you need to ask any questions? Okay, who is the third presentation? I will give you 15 minutes.
Can you see my slide?
Yes.
Okay, so the second case is the next case is endocrinology system. So here my table of content. My patient, Nurul Ain, 12 years old Malay girl, referred to HTAA from Hospital Rompain due to lethargy for 1 month duration. Okay, so history of presenting illness. She was previously well until 1 month ago, where she felt lethargic, and in which she had to sleep about 12 hours per day. She always feels sleepy and fall asleep in class. She also went straight to sleep after coming back from school. Her mother had to wake her up for dinner and shower. Her mother complains that she is no longer helping her with the house chores. Recently, she was absent from school for 4 days due to excessive lethargy and sleepiness. Furthermore, her excessive sleepiness was also associated with increase in urine frequency for 1 month, despite of her normal water intake per day. Her normal urine habit is 4 times per day. She also complained of enuresis for 1 month. Her mother claimed that she had this problem since childhood, but it became worsened during this current presentation. In addition, she also noticed that she is having frothy urine 2 weeks prior to the admission. The patient noticed that she had lost weight about 10 kilogram in 2 months, despite her normal diet and appetite. For her eating habits, she often took sweet drinks and packet drinks twice a day. She also likes to eat white rice, and occasionally she would take her fruits and vegetables. Her mother checked her capillary blood glucose using over-the-counter dextrose stick, and the reading was around 15 to 80 millimole per liter in 3 days monitoring. So she brought her child to Hospital Rompain. At Hospital Rompain, her fasting and random blood glucose is 30 millimole per liter and 22 millimole per liter respectively. Film was done, and the result revealed protein 2+ and glucose 3+. Her dextrose stick monitoring recorded 8.2, which is the lowest value, and up to 25.7, the highest value. In view of the high glucose reading, she was given IV Atrapid 10 units. Otherwise, she had no endemic symptoms, no other urinary symptoms such as nocturia, dysuria, hesitancy, hematuria, no signs and symptoms of diabetic ketoacidosis such as blurry of vision, nausea and vomiting, deep and heavy breathing, fruity smelling breath, and abdominal pain. She also had no hypoglycemic symptom such as dizziness, tremor, sweating, increased hunger, seizure, and loss of consciousness. So for other history, past medical history, she had no known medical illness. This is her second hospitalization, where the first one is when she was admitted to NICU at day 3 of life due to neonatal jaundice. For drug history, she is not taking any medication and she had no drug allergy. For immunization history, she had completed vaccination up to age, no additional vaccine taken, and no allergic reaction. For birth history, the antenatal and intrapartum was uneventful. So postnatal, she had neonatal jaundice at day 3 of life for 1 week. For nutritional history, as I mentioned earlier, she likes to drink sweet and packet drinks twice a day. She likes to eat white rice, likes to snack in between her meal, occasionally eats her fruits and vegetables. For family history, she had a family history of thalassemia trait. Father, age 56 years old, had hyperlipidemia and ischemic heart disease. Mother, age 49 years old, had hypertension, hyperlipidemia, and diabetes mellitus. Mother is a thalassemia carrier. Other family members is not screened for thalassemia. So social history, she is a standard 6 student. She is in 2nd class, and she is placed 24th out of 27 students in her class. She is an active student in her extra co-curricular activities. So for physical examination, general examination, she was conscious, comfortable, oriented to time, place, and person. She had medium build, body build, no dysmorphic features, warm hands, no clubbing, peripheral cyanosis, no clubbing and peripheral cyanosis, no jaundice and conjunctiva pallor. Her hydration status was good. There is acanthosis nigricans noted at the nape of her neck. No manifestation of skin infection. So for vital sign, her blood pressure is 117/72 millimeter mercury, just normal. Pulse rate 100 beats per minute. Respiratory rate 20 breath per minute. Temperature 37 degrees Celsius. For her anthropometric measurement, she is her BMI is obese, class 1. Okay, for other system, fundoscopy was done, no sign of the diabetic retinopathy. However, glaucoma is suspected. Other systemic examination were unremarkable. So for summary, my patient, a 12-year-old Malay girl, presented with excessive lethargy, polyuria, and enuresis for 1 month duration. It was also associated with weight loss for 2 months. She had family history of thalassemia and first-degree related diabetes mellitus. On examination, she is medium build, obese, class 1. There is also presence of acanthosis nigricans, which suggestive of insulin-resistant diabetes mellitus. So my provisional diagnosis is type 2 diabetes mellitus. Points suggest is she had lethargy, polyuria, secondary enuresis, obese type 1, weight loss, and acanthosis nigricans. Points against, there is no polyphagia, no polydipsia, no DKA symptom, and no skin infection manifestation. So for differential diagnosis, type 1, and the first one is type 1 diabetes mellitus. Point suggesting is lethargy, frequent urination, primary enuresis, and unintended weight loss. For points against, usually type 1 diabetes mellitus, age onset is younger, thin build, and also in this patient, there is presence of signs of insulin resistance. My second differential diagnosis is thalassemia. Point suggestive is she is lethargy and mother is a thalassemia carrier. Points against is there is no other anemic symptoms and other family members are not screened for thalassemia. So my third differential is hypothyroidism.
I keep it for you here. To give it to Dean. This is for my conference. Okay, thank you. Yes, sorry, you can continue.
Okay. So my third differential is hypothyroidism. It is point suggesting is she is lethargy, not yet attained puberty. So points against is weight loss, and she had no other symptoms suggesting of hypothyroidism. My fourth is diabetic ketoacidosis. Point suggestive is lethargy, polyuria, and weight loss. Points against is there is no other symptoms that is suggesting of diabetic ketoacidosis. So my fifth differential is urinary tract infection. Point suggesting polyuria, increased frequency in urination. Points against is no other urinary tract infection. She had no fever. So my last differential is adrenal insufficiency. Point suggesting is lethargy and weight loss. Points against, no abdominal pain, muscle weakness, or loss of appetite. Okay, so for this the investigation. So for the blood investigation, full blood count was done, and the hemoglobin level was normal. Random and fasting blood glucose was done, and the result is she is hyperglycemia. HbA1c also done, but the result is pending. She also had deranged lipid profile where the cholesterol, HDL, LDL, and triglyceride is high. Urine UVME result is protein 2+ and glucose 3+. However, for leukocyte, ketone, and nitrite, negative. The other investigation done is autoimmune antibody with anti-islet JAD antibody, protein tyrosine phosphatase antibody, and C-peptide, but the result is pending. Okay, for the management, she was given IV atrapid 10 unit. Then post injection, the blood sugar lowers to 12.2 millimole per liter, and she also done daily dextrostic monitoring. And then she also start on metformin 500 mg BD. And for non-pharmacological, patient was given counseling on diabetic diet and healthy lifestyle. She is also encouraged to exercise 100 as per WHO recommendation, 150 minutes per week or 30 minutes per day for moderate intensity exercise. Refer dietitian and physiotherapy for lifestyle modification. Patient also is referred to ophthalmology for eye assessment. And she also can be referred to nephrology and vascular specialist for macro and microvascular complication assessment. Okay, that's all for my presentation.
Okay, good. I was needing it for some points. How many types of diabetes do you know?
Doctor, sorry?
Types of diabetes do you know? Now you said it is type 2. Do you have another? So we have type 1,
Type 1 and
Type
type 2.
And MODY.
MODY and gestational diabetes and the drug-induced diabetes. So you must be able to know it is a wide one. Okay, so your patient is MODY or type 2? Usually if there is strong family history and start in younger age and he has this, you said that I can say sometimes you need some genetic study to rule out it is MODY, because MODY usually responds very nice to metformin. Okay, this is number one. Number two, for differential diagnosis, you can come back to the slide of differential diagnosis. So it is very important if you found someone who is eating more and lose weight to think about many cases, okay? Diabetes mellitus and hyperthyroidism. Hyperthyroidism are very anxious and eating and lose weight like that, okay? So it must be put in the differential diagnosis. For hypothyroidism, yes, we must include because we have now like multi-endocrinal gland can be affected. So it is only diabetes or have another one. Sometimes you can find adrenal, you can find thyroid abnormality, you can find pituitary. So in the sometime while examining clinically and investigation, you may consider this one. The other point in the treatment is number one is the lifestyle, which include exercise and diet, and we must refer the patient to subspecialty, which is the dietitian, will help him for the healthy diet, and even you are sending him to physiotherapy for exercise, because without exercise, the blood sugar will not be adjusted. We need normal life. We need also to education. This is one of the points. We need to educate the patient how to measure the RPS and how can give him the treatment for himself or given by supervision by under one of the family, and how I can follow up the urine if he need to make dipstick to check. All these are very important. Okay, so it is a part of management. The patient with chronic disease, we must be very intimate relation, and we need to teach him a lot of things which make his life near normal. You must teach the patient types of coma. He can get hypoglycemic coma, hyperglycemic coma, and the other types. So we must teach them about that so the family will know what to intervene. Like I said, the family, if your patient started to lose consciousness, you can give him some sugar. Even I suspect it is high, no difference to be high from 30 to 31. But to increase this one for hypoglycemia, you can save his life. So there is a lot of details, but you must say, I need to lead this patient with a multi-team. Okay, I must include blah, 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 and I must send him for health education, or I'm making a counseling for him, which are very important. Okay, generally, you must know the names of insulin, ultra short, medium, okay, long-acting penicillin, and the new generations. Thank you for this one. The last point, which you mustn't forget also, there is diabetes mellitus and there is diabetes insipidus. So insipidus has diabetes also, but it is frequency due to osmolarity and like that. So we must consider their osmolarity and the other plasma osmolarity if we suspect diabetes insipidus. And there is some disease combine both of them, diabetes insipidus and the diabetes mellitus, known as DMI, DDI, which is diabetes insipidus. DM is diabetes mellitus. MOAD, I think there is abnormality in the eye and different system. You can just go for DID-MOAD and revise it. Okay. Thank you for your nice presentation today.
Doctor?
Yes.
Yeah. So for the differential diagnosis, I can add another one more D and diabetes insipidus.
Yes, diabetes insipidus and hyperthyroidism also.
Sorry?
Hyperthyroidism.
Oh, hyperthyroidism, okay.
Yes. Okay. Thank you very much. Now it's time to pray. Feel free to ask me for anything. I send you your colleague just 30 years he did, for my opinion, collecting a good job, and I got permission and send it to you to see every one of you better to do his flow. But just to remember that I must know my flow during the exam. I will go directly. I know what is the next step. There is no time to think what is the next step. First, second day, and from every step I need to pick the positive thing, like I'm picking flower, 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 until I make like bouquet and give it to the examiner. Otherwise, I will cry. Okay? Make your life, inshallah, systematized. You will get the best results. Keep in touch if you need, and if you are able to amend these slides and send it also, it may be give some benefit for the others. Okay? Thank you. And see you. I will send your marking to Sister Farah, inshallah.
All right.
Okay.
Doctor, I would like to inform that we are your mentee for this posting.
Sorry?
I would like to inform and update that we, Group 3, are your mentee for this posting.
Okay, even if you are not my mentee, you are welcome, but you can contact me for any help, even if you need another simple session for to complete yourself for anything, I am welcoming. Okay?
Okay, doctor.
See you inshallah soon. Assalamu alaikum wa rahmatullah.
Waalaikumsalam. Thank you, doctor.
Thank you, doctor.
Thank you, doctor.